Great, thank you. So thanks again for the introduction, and thanks to Trauma Care for asking me to contribute to this webinar series. I'm an interventional radiologist at Queen Elizabeth Hospital in Birmingham. I've been a consultant there for probably 13 years now. And we see a lot of trauma cases in our practice. So I'm going to share with you some of my experience and some of the challenges that we face in interventional radiology, and overall give you a flavor for the role of interventional radiology in trauma. I appreciate that there's a variety of different specialties and healthcare professionals on here tonight. So I've tried to cater for everyone in terms of what the content is here. So I just wanted to start off with a slide really of historical interest. This is the first publication that mentions the use of interventional radiology in trauma. This was published in the New England Journal of Medicine in 1972, and it describes the use of autologous blood clot to treat hemorrhaging arteries in 3 patients with pelvic fractures. So this is the transcatheter injection of autologous blood clot to embolize trauma, so embolize bleeding pelvic arteries. So the concept of interventional radiology in trauma is not new. This paper is nearly 50 years old. So the objectives of my talk this evening are to review the evidence in support of interventional radiology, and clearly in the last 50 years there's been a lot of advancements, not only in the techniques but in the understanding and the evidence to support that. We'll discuss the role of IR in trauma, and perhaps what is important for us to discuss is when is interventional radiology appropriate? When is the best time to call us and involve us? And as I've already alluded to, we'll look at some of the challenges that we face in getting patients to interventional radiology. So our role, plain and simple, is to diagnose and stop bleeding. I've written here avoid surgery, but it's important to point out, I'm not saying this is a direct replacement for surgery, but if we can avoid surgery and provide a definitive treatment with a minimally invasive embolization, for example, then that's probably in the best interests of the patient, therefore avoiding additional trauma caused by surgery. We can be synergistic with surgery in that we can provide preoperative optimization of the patient. An example of that would be the use of an occlusion balloon, such as the Roboa balloon, just as an example. But the most important point on this slide is that each case should be multidisciplinary in order to get the best results and the best outcome for the patient. So this is for the benefit of those of you who have perhaps never been into an interventional radiology suite, although I respect that probably most of you have. So this is simply an X-ray system, if I can get the laser pointer working here. This is a C-arm, so the X-ray source is at the bottom here. Patient lies on this table, and then this detector plate here detects the X-rays, and then we can see live fluoroscopy on this screen here. And for the purposes of trauma, most of the interventions that we do are carried out via a femoral artery access in the groin. And we access the femoral artery using a needle and a wire in a Seldinger technique. And then we introduce one of these vascular sheaths. And this just happens to be a picture here at the top of the screen that you can see. So all our catheters and wires. So this is an example of a wire here, which we place into the artery through this sheath. And then we can run a catheter over that. And catheters come in all different shapes and sizes, depending on what vessel we want to access. And we've got a good idea and understanding through our training of where the arteries are, but we need to inject X-ray dye or contrast through these hollow catheters in order for us to see the blood vessels on the fluoroscopy screen, because they are not visible. Just the bones are going to be visible. So we inject X-ray dye through these catheters to provide a roadmap for the blood vessels. And our input really is in this first sort of hour or so following presentation, where blood loss is the most significant, and we can help to staunch that blood loss. Okay, so let's look at before the patient even comes to interventional radiology. So this is a picture of one of the first CT scanners. This is probably from the early 70s when CT first was invented. And you can imagine trying to take a trauma patient through that. That's not going to happen. But nowadays, in the modern world, modern CT scanners can scan a whole body in under 20 seconds. And it provides an essential guide to treatment in the modern trauma care pathways. So there shouldn't really be any delay to CT. I understand that, in certain circumstances, if the patient is crashing and there's obvious intra-abdominal injuries, they go straight to theatre for a laparotomy. But I think more and more nowadays, most patients are getting a CT scan before any further treatment. And most CT suites are set up for ongoing resuscitation of patients during the scan. And I've just made a reference here at the bottom of the screen. This was a large trial that was looked at, was presented in the Lancet in 2009 and showed that if you scan the patient early, it makes a significant impact on survival in a positive sense. So CT for most patients here is going to be essential. Why have I put this document up when it's nearly 14 years old? I think it's still poignant because prior to this, there was a low use of interventional radiology. And I understand in some centers that might still be the case. I work in a large trauma center where we've got a full on-call 24/7. There's 12 of us on the rota, but I appreciate that might not be the same in every single hospital. But this document from 2007 demonstrated that the low use of IR put lives at risk, and it demonstrated also that there was a 20% higher mortality in England and Wales compared to the USA. So it just sort of puts things into perspective, really. So much so that now there are nice guidelines for interventional radiology and trauma, and you can read these on the screen. I don't really need to read these out, but it basically points out the hospital should have provision for interventional radiology, particularly in the use of embolization for acute arterial pelvic hemorrhage, unless, of course, the patient needs open surgery for other catastrophic injuries. It says here also consider interventional radiology in patients with solid organ injury or arterial hemorrhage. And similarly, the bottom of the screen here, stent grafts for patients with thoracic aortic injury. And we'll address each one of these points in the coming slides. So the key to success, if you take nothing away from this talk this evening, just take home this point. The key to success in terms of how much interventional radiology can improve the situation for your patient is our early involvement. I can't stress that enough. And there's good evidence out there that demonstrates this. This paper, albeit from 1997, demonstrated that if you delayed pelvic embolization beyond 3 hours, the survival rate dropped. Similarly, a large study here, 635 patients for interventional radiology, a delay to interventional radiology equaled a twofold increase in mortality. And mortality risk was increased by 47% with every hour delay. I think it's fair to say often our input is perhaps thought of after that golden hour, but we really need to be involved early if our techniques are going to work. The longer you leave a patient for embolization, the more likely they are going to develop a coagulopathy, and the embolization isn't going to be as successful as you'd hoped. And often in cases where interventional radiology or embolization is criticized as perhaps being not very efficacious, it's usually associated with a significant delay to getting the patient to the angio room. So what can we do? What are the treatment modalities? Well, you've got transarterial embolization. That forms the bulk of what we can do in terms of trauma. And here's just some examples of how we embolize patients. So this is an embolization coil, okay, and this will basically stretch out like a wire that we can place down one of those catheters that I showed on the earlier slide. The catheter tip will be placed at the site or around the site of the hemorrhage, depending on the anatomy. And then we can place one of these coils. And you can see these fibers that are on this platinum coil here. These cause a blood clot to form in that area. So as well as forming a partial mechanical occlusion, you require the use of, or rather you require the body's own clotting system to be able to work as well to form a plug. There are newer coils that form mechanical occlusion, and perhaps they are going going to be shown to perhaps improve the situation in terms of trauma patients because they cause a mechanical occlusion and don't necessarily rely on the clotting system. This is histoacral glue, just like you use in your emergency departments, and we can inject that down into a bleeding vessel as well through a catheter. So these are just two examples of permanent embolization agents. Gel foam, which is just basically gelatin sponge, and this can be injected as little pledgets, as you see here, down a catheter, or you can mix it into a slurry by mixing it with contrast and inject this slurry down. And this is essentially a temporary embolization agent, and this can be used in non-selective arterial embolization of pelvic arterial injury, and we've got an example of that coming up shortly. Balloon occlusion. So we can place an occlusion balloon in the blood vessel under X-ray control proximal to the site of injury. And I understand there's a lot of interest of recent in the Reboa balloon, and effectively that's an example of a balloon occlusion. So we can optimize the patient preoperatively. So whilst you're mobilizing theaters and getting more definitive treatment plans in place, and we can occlude the blood vessel to prevent further or temporize hemorrhage. And then stents and stent grafts are used more and more nowadays in trauma patients in general. This is a stent. So a stent is basically a metal tube with an open sort of matrix to it. So blood can flow through the side of this. So that's not ideal necessarily if you've got a patient with a bleeding vessel or medium-sized vessel, because the blood will just still leak through here. But a stent graft has a PTFE lining. So this essentially forms a new blood vessel, if you like. It forms a new lumen, so excludes any artery damage here when it's placed in the patient. It doesn't get placed in the vessel when it's in its form like this. This is when it's fully expanded. It's actually contracted or constricted rather on the catheter that we introduce it, and then we deploy it when it's at its target point from outside the body, and different stents deploy in different ways. This is just an example of a gunshot wound to a left subclavian artery. So this is an angiogram. This thing that you see here at the bottom of the screen, this is a pigtail catheter. So a hollow catheter placed all the way from the femoral artery up through the aorta into the proximal left subclavian artery. This is what you're seeing here. And this is an angiogram demonstrating the left subclavian artery, the left vertebral artery, and you'll see this abnormal area here. This is a large pseudoaneurysm and a rupture of this subclavian artery caused by this bullet. The dense area there is the bullet, which has fractured the clavicle also. So there's a lacerated subclavian artery. And our intention here initially was to put an occlusion balloon in to temporize the situation, but we were able to place a stent graft. So moving back a few slides, I placed one of these devices in that area, and we were able to exclude that pseudoaneurysm, so thereby providing a definitive minimally invasive treatment and therefore avoiding surgery in this patient. This is another example of a young man who was impaled on a fence. And this picture at the top left-hand corner of the screen is an angiogram, again, taken from the femoral artery. The catheter tip is here, and we're injecting contrast. And you can see it's not really going anywhere. It's sort of just, it's static here because there's a laceration or dissection of the right axillary artery. I was able to place a similar device in there, another stent graft. You can see the end of it here and here to restore flow in that vessel. And you can see the final image here where we're injecting X-ray dye or contrast shows flow back into the arm, which you did not see on that first picture. So again, this patient avoided surgery by the use of a minimally invasive angiogram followed by deployment of a stent graft. And we're finding more and more nowadays that these devices have good medium and long-term patency similar to surgical grafts. Earlier on in our experience, there was little known about the longevity of them, but certainly there's good evidence to suggest that these devices are as durable as surgical grafts. So let's look at pelvic injury next. So I don't need to tell most of you, I'm sure all of you know that hemorrhagic shock is a significant cause of mortality in patients with pelvic fractures. For the most part, bleeding in the pelvis associated with fractures is venous. It's only thought to be around 10 to 20% that is actually arterial. And most venous bleeding can be addressed using external fixation. But it's the arterial bleeders here that really we can make the biggest impact on in interventional radiology. And these are the patients that are not going to respond to external fixation. And this diagram here just illustrates some of the common areas where we see arterial injury in pelvic fractures here at the sacroiliac region, and then at the obturator region here as well. And this is the leading cause of death in pelvic injury. And there's a whole debate, I'm sure this will go on for many years, is which is better, embolization or packing. I don't think there's necessarily a right or wrong answer to this. I think it boils down to the individual patient, because there are many pros and cons for both. But there's no doubt that in a patient with a higher injury severity score, surgery is probably going to yield a better outcome, especially when there's other internal injuries. So laparotomy might, in many cases, be the most appropriate first-line treatment. But what are the indications for embolization? When should you consider involving us? Well, I'd say that you should probably involve us in all of these cases, even if it's just for discussion. But the patients that are going to benefit most from embolization are the ones that are persistently unstable, despite having a pelvic binder. And nowadays, most patients will have had a CT, and you can see that vascular injury on CT or hematoma. Remember, you have to have active bleeding at the time of the scan in order to demonstrate extravasation. So a large hematoma can still be an arterial injury, even if there's no extravasation. Also transient responders, so those that are intermittently bleeding, probably because they get an intermittent tamponade of a deep pelvic artery. So the transient responders, again, that's a red flag, and we should really consider those patients for an angio with a view to embolization. And again, if you've taken your patient to theatre and you've done pack-in or whatever technique you use, it's often that you might find that there's a small artery that's not been located. Even after surgery, you can still consider an angio with a view to embolization. And I've been involved in many cases like that. This is just an illustration of, some of these papers now I'm quoting here are quite a few years old, but nonetheless, the technical success rates in terms of angiographic success in showing that you've treated a bleeding vessel are high. But most importantly, a lot of these papers here have reported high rates of clinical success, which is of utmost importance. We don't just treat pictures, we can make everything look great on an angio, but really at the end of the day, are we making a difference to the patient? And these papers have illustrated that, yes, we are. So this is just an illustration of a pelvic, I haven't got the CT scan, but this is a patient that was involved in a road traffic accident, and there was a large hematoma, as I recall, on the CT. And this line that you see here is the diagnostic catheter from the opposite femoral artery, and the tip of the catheter, which is just here at the top of the screen, an angiogram being carried out. To the untrained eye, this might look like a normal angiogram, but if you focus on this area here, and I hope you can all see my laser pointer, I can see it on the screen here, but you see an amputated artery there, which is going to be the cause of the bleeding. And that's just a zoomed up version for you to see there. There's the tip of my catheter where that wire is, sorry, that arrow is rather. And as you see, when I'm doing this angiogram now, I'm getting some extravasation. So just where that red arrow is, the whole thing starts to bleed at the time of the angiogram. So this patient would probably fit into that transient responder group where they're intermittently bleeding. And you can see there's quite significant extravasation here. So I was able to place embolization coils, and you can probably just about make them out on this digital subtraction image. We coiled across that branch. That branch is insignificant, so we can sacrifice that branch, and most of the vessels beyond that will then collateralize in the rich collateral network of the pelvis. That just illustrates the coils. So when it comes to who should have embolization, who should have packing, again, I suspect this is going to be an ongoing debate for many years, but there are many advantages to both. Embolization is effective, packing is effective. Embolization, of course, is minimally invasive. One of the criticisms of embolization, it takes a long time to get the patient to angio and so on and so forth, whereas packing has been shown to perhaps be a bit quicker. Delays to embolization, and we're going to discuss that and explore that in a little bit more detail in the coming slides. Also, some of the criticisms are length of the procedure, but in our experience, most of these procedures do not take a long time. Sometimes they can be protracted if you've got multiple bleeding vessels, but for the most part, they can be quite quick procedures. And of course, the advantage again of packing, you can still consider transarterial embolization if the patient remains stable afterwards. But as I've already alluded to, one of the take-home point for this webinar this evening is if you want interventional radiology to work, if you want embolization to work, time is of the essence. And again, these are just some illustrations of papers that have demonstrated that where mortality rates are much higher when you refer the patients late for embolization. So some of the delays to IR that I just alluded to, and some of the common criticisms, perhaps, if you like, perhaps that's a bit of a strong word, but certainly some of the discussion points are that we're not on site. There are mobilization times to consider. Well, in most major trauma centers, our mobilization time is 30 minutes. And I know in our experience, we can be on site within 30 minutes. Some of the other times some of the other issues that we find is that we're in the department, in the hospital, but there's a lot of delay getting the patient to the department, and we understand that there's a lot of these polytrauma patients are going to have head injuries, chest injuries, and so on and so forth. So you need senior specialty input from multiple specialties, and there's lots of decisions to be made. So that can often perhaps be more streamlined, but we understand that can take some time to try to decipher, to try to figure out exactly what is the most life-threatening injury to that patient at that time. And that can take some time to establish. And then, of course, you've got the logistics of transfer to angio. One of the other things that we commonly encounter is that the patient is having CVP lines. And we understand, of course, you need to try and get the patient as stable as possible and be able to monitor CVP and so on and so forth. But until we stop the bleeding, the patient is going to remain unstable. So really, we should be considered the same as the operating theatre in that we can provide definitive treatment and we can advise on whether or not we can do that. So getting the patient to angio shouldn't really be any different to getting the patient to theatre. I've put wards here, I've written this down because we've had situations where we're told the patient can't come to angio until there's a bed on a trauma ward or something on those lines. So these are the sorts of things that sometimes can cause delay to angio. So these are some things that we can consider, but I've put here, don't throw the baby out with the bathwater. Okay, we can explore these logistics and pathways, and no doubt every trauma center is going to have its own logistical issues, not necessarily the same everywhere. You can audit this sort of thing. We can educate each other on our relevant specialties. Hybrid theatre, that's of utmost importance, I think. I think nowadays most hospitals will have some form of hybrid theatre, and that perhaps will provide a more familiar environment to the rest of the trauma team and allow us to provide definitive treatment by way of embolization or stenting or whatever it may be. This is just a case of a patient, just to illustrate a different way of approaching a pelvic bleed. This is an elderly patient that was run over by a car, massive hematoma in the pelvis, unstable. This is an angiogram taken in the superior gluteal artery. I can't remember, it looks like the right side here. You can see these multiple areas of extravasation, and there's no way we're going to be able to coil each one of these and target it. So we could use gel foam in a case like this, which is what we did here, and just embolize the whole lot there. There are risks of causing buttock necrosis and so on and so forth. So you have to be careful, but those risks are low, and you have to balance those risks against the patient remaining unstable. And certainly, I'm sure most surgeons would agree, it would be difficult to treat that even if you went in there and opened up that hematoma, because there's so many small arteries that are bleeding. So it's a balance. Okay, let's move on to solid organ trauma. So I've seen in the last 12 or 13 years us being involved in more, or in rather in higher grade injuries of solid organ trauma, and certainly the evidence in the literature points towards more durable results, even in higher grade injuries of solid organs. We know that operative management carries a mortality, and so does non-operative management. And failure of non-operative management in splenic injuries around 30%. So there is this trend for us treating more and more unstable patients with success. This is just a case example of a patient that jumped out of a window, as I recall. This is a CT scan that shows an obvious area of vascular abnormality there at the hepatic hilum, where the arrow is. This is the corresponding angiogram. So this catheter that you see here is placed through the celiac axis from the femoral artery. This is the gastroduodenal artery here, and you can see the liver here. You can see the capsule of the liver and the parenchymal phase. This is the right hepatic artery, but this area here, this is a pseudoaneurysm of a transected left hepatic artery, and to access that surgically, I'm told, would be very difficult. But we were able to put coils in there and stop that bleed, exclude that pseudoaneurysm from the circulation, and provide definitive treatment to this patient without the need for an open operation. So that's just another illustration of us accessing areas that are going to be surgically difficult to get at. Patient involved in a automobile road accident, fractured spleen here. You can see this is a coronal reconstruction. This is the level of detail that we get on trauma scans if you haven't seen one before. So you get high level detail. And there's this area in the spleen here. There's a splenic laceration with extravasation contrast. It's a splenic angiogram. So this patient was intermittently unstable, and this was really the only cause of that instability. It was a young patient, and we were able to do a splenic angiogram. This is a catheter. You can see it coming up from the groin here, placed in the celiac axis. This is the splenic artery, and they're often tortuous like this. And you can see out here in the spleen these areas of extravasation or pseudoaneurysms. We're not actually seeing any spill of contrast into the peritoneum, but often these are a slow leak through the splenic capsule. So we're able to then place some embolization coils through that catheter in the proximal splenic artery. And you can see here how it's occluded the splenic artery, but we've still got collateral supply to the spleen. So the spleen will remain perfused in part, but we've reduced the pressure head to the spleen and therefore reduced the risk of further bleeding. Of course, if this failed, then the patient might require a splenectomy. One of the complications of a splenic embolization, again, is formation of an abscess. So 2 months later, this patient gets an abscess in the spleen. We're able to place a drain in that, and they did well with that drain. And the risk of that is around 10 to 15% of developing a splenic complication. But again, this patient avoided an open operation, both at the index procedure and later on, because we were able to provide a drain to drain that abscess. And you can see that there's still enhancing splenic parenchyma there, so the patient still will have some splenic function. This is an example of a renal trauma. So then this just highlights the timelines that we were just discussing in one of the previous slides. So this is a 25-year-old man that was stabbed, was unstable in the emergency department. This was really the only, he had some other, I think, some superficial injuries, but this was really the only sort of life-threatening injury. And you can see on this CT scan, there's disruption of the right kidney, the left kidney over here. Remember, CTs are when you look at them, they're the other way around, just like chest x-rays. So this is the left kidney. This is the right. So there's obvious disruption of the renal parenchyma here. There's a big hematoma, this gray stuff around here. This is blood hematoma. All these sort of black dots here in the soft tissues. This is air where the knife has gone in. So you had a CT scan at midnight. We were called at 2 a.m. We were there at 2:35, and a patient and an angio at 4. So there was not necessarily the quickest patient into angio, but nonetheless we were able to provide a definitive treatment by coiling the offending renal branch arteries and save some of the function in that kidney. If that patient would have gone to the theatre, there's no doubt they would have had a nephrectomy. But this CT scan was taken, I can't remember the exact time frame, but some weeks later, and you can see that the hematoma around the kidney has largely resolved. You can see the artifact from the embolization coils there, and you've got normal enhancement of the renal parenchyma. So they will have lost some of their renal tissue there, but the bulk of it is preserved by this more targeted therapy of embolization. I just want to finish up on this case. This is an actual case I was involved in. It's probably, I don't know, more than 10 years ago. This was a young man who was involved in the early hours of the morning in a head-on road traffic collision. Was taken to another hospital around 20 miles from my hospital in Birmingham, and he had a fractured aorta. You can see this blowout here of his proximal descending thoracic aorta, and these are the injuries that usually kill people at road traffic accidents, either these injuries or massive neurological trauma. But this is a very unstable injury of the proximal aorta. Second commonest cause of death. 30% die within 6 hours, and the surgical mortality is 30%. 30-day mortality with IR is less than 14%. And there's increasing risk with every hour this patient is left untreated. There was lots of logistical problems with this, transferring this patient to our hospital, one thing and another. I can't remember the exact reasons, but this is the angiogram I did 12 hours after the initial injury. When he first arrived at our hospital, he was brought straight to angio. We were able to put a stent graft in there and provide definitive treatment to this young man. And we follow these patients up, and years later, this remains patent with no complication. So you can see how significant this injury is here in this descending thoracic aorta. So that's just an example of a thoracic aortic stent graft, and we know that the treatment now for these patients with these transected aortas is a stent graft regardless of age. So to conclude, the take-home messages, I hope I've given you a flavor of what we can provide in interventional radiology. We can save lives, but we need to be involved early. That multidisciplinary discussion is really key and early on. So thank you very much for your attention, and hopefully we'll have some questions